where they have reported that there was rise in hemoglobin and rise in ferritin, and the mean rise in hemoglobin in FCM group was higher as compared to the IVR and sucrose. I just want to mention here that at 3 weeks and 12 weeks in the first study, it was mean rise in hemoglobin FCM group was 2.03 plus or minus 0.47 at 3 weeks. And at 12 weeks, it was 3.86. So there was a consistent improvement in the hemoglobin and ferritin levels. And all these studies reported no serious adverse events. So coming to some of the studies in the postpartum period. So this was one of the studies, Rathod et al., where they compared FCM versus iron, sucrose versus oral iron in treatment of anemia. This was a sample size of 366 with the pregnant woman of less than 10. Here also the results are consistent. I just put all these studies in pregnant women into the in a map of India. We can see there are studies. It's all about IVRN studies around pregnancy in India, and all have reported significant and consistent results. There are studies which studied iron, sucrose versus oral iron. Safety here in this study, the safety and study which studied iron, sucrose versus oral iron. Safety here in this study, the safety and clinical effectiveness have been studied. This was a multi-center, open-label, randomized control trial study in pregnant women of 20 to 32 weeks with hemoglobin of 5 to 9 gram. They have compared treated with IV iron group in one arm and standard oral iron therapy. And in this study, the clinical the efficacy was measured by a composite of potential of demonstrable difference between the intervention and control group dream analysis. We thought about maybe semantic manner how it conducted, and these composite indicators interpretations are difficult. There are studies, systematic reviews, and meta-analysis. One of the meta-analysis is ferricarboxy maltose where iron sucrose, in which all the studies the quoted are from the Indian scenario. So it also reported that FCMEs had a higher mean hemoglobin level as compared to the iron sucrose group. Similarly, there is another FCM for effect of IV iron, IV ferricarboxy maltose for moderate or severe anemia, a systematic review and meta-analysis recently published in 2024 in February. They have taken, they have identified nearly 250 clinical studies, and they have collated 10 studies specifically for the meta-analysis. And in these studies also, at 12 weeks, all studies have shown significant improvement in hemoglobin. And the risk of adverse events in the FCM group was 48% less than iron sucrose group, which is relative risk of 0.52. So these are the main Indian studies, clinical randomized control trials and systematic reviews and meta-analysis specifically for Indian population. Coming to my last slide, take home message, severe public health problem. Mean rise in hemoglobin in IV iron was higher at 3 to 4 weeks and sustained till 12 weeks. Mean rise in ferritin levels in the IV iron was higher as compared to oral iron. There are extensive evidence from various parts of India supporting this evidence. There are no serious adverse effects reported in the IV group in any of these studies. Thank you.
Thank you very much. The oral iron, which has its own controversies, even issues with compliance, issues with absorption, issues with adverse effects, and also the issues, the new thoughts about the dosing of alternate days or once a week and so on and so forth, and taken us through the present and probably the future new era of the parental iron, which may stand the test of time. iron being in the center with all other supportive components like proteins and the B12 and folic acid, which was brought to light in the previous discussion as well. Thank you very much, Tejas. So next, the space of OBGYNs, the women's healthcare. And we at FIGO, which is the International Organization of OBGYN, strongly believe that there should be a life course or the life cycle approach. At every point in her life, a girl and women should be in readiness and preparedness for the next phase of life. So whether it's an adolescent prior to her first pregnancy or it's an interpregnancy, before she embarks into the pregnancy, can we make her better? So that's the thought process, not to miss the opportunities. The storytelling experience that Gomti gave, which would stay in everybody's mind, even the affluent, whether it's urban or rural, yesterday, but I hope again a better tomorrow. So Aparna on the experience in India through AIMS in the space of dealing with anemia to march towards.
Thank you, ma'am. Respected chairperson, senior faculty, colleagues. Today I'll be talking about what our department has done specifically and our experience with the use of intravenous iron. So I would like to just talk about, the studies which have come out from AIMS, our department, and a little bit about how FCM is being used in our department right now in a data of last 1 year only. So till now, from our department, we've had 2 RCTs, 1 observational study and 1 systematic review. So I'll be just going through these studies in a little detail, just to give the impression that I think for the clinical purposes, we are very comfortable using IV iron. So I think there has been a lot of evidence, and somehow from 2016 onwards, in fact, starting from 2013. So this was a paper, the most recent one is a little bit what 2019 we had done a meta-analysis with the support of NCEAR also. So doctor has given an overview. So there was a pregnant women who were between 16 to 36 weeks. And the change in intervention was FCM in pregnant women. The control was iron sucrose, and the outcome was change in hemoglobin from baseline at 12 weeks. So it was an RCT between 16 to 17, and the sample size was 100 women. It was seen that this rise in hemoglobin at 12 weeks was more with FCM group to the extent of almost 3 gram percent versus 2 gram percent in the iron sucrose group. In the ferritin group, regarding the ferritin at 3 weeks, it was more in FCM group, while at 12 weeks, it is comparable. So it goes to show that it leads to an early rise and replenishment of iron stores that we have been talking about. In terms of iron requirement, how much of iron was given? So we had around 1700 milligram given in both the groups, but the number of doses, as is really important from the programmatic point of view, because number of times a woman is going to come to us for iron sucrose. So I think this was one interesting finding, and the time required to administer the total dose was 1 week as compared to 3 weeks. So these are some of the practical problems that we face when we scale it up. So these were important findings in the study that we would like to emphasize. And there was transient asymptomatic phosphatemia in both the groups, but not significantly different, and resolved at 12 weeks follow-up. No serious adverse effects and no adverse perinatal outcome. In terms of cost, the cost was almost similar in terms of a single dose versus a multiple dose, but this did not include the cost of travel, work days lost due to so this was a rough analysis which was done in terms of just the cost of the medication, but the implication of multiple visits and all of those things were not taken into consideration. So it was felt that FCM has a higher and rapid replenishment of iron stores. So it is suitable especially for the women in the 3rd trimester. Also, even with the comparable iron stores by 12 week, quality of life and fatigue improvement was felt to be better in FCM. So these were some, because there was also an assessment of the quality of life score. So these were some of the important findings that were felt in terms of FCM versus iron sucrose. So if we see that at 6 weeks, another important point that I would like to make here is, and that we have been also saying, that when is actually an improvement seen when we give iron. So we see that, at 6 weeks, the women are mostly coming out of that anemic range. So I think that was observed, and it was persistent at 12 weeks. So while at 3 weeks, there was a rise in hemoglobin, but it coming into the mild range. So I think these are some of the important points that we ask ourselves the question: how frequent or how fast is going to be the response? Is rise important, or going out of the anemia range important? I think these are some of the questions that have to be done. Now, this was another study using FCM and iron sucrose for abnormal uterine bleeding. So I think in reproductive age group, this is also an important fact. So in women who are more than 18 years, FCM was compared with iron sucrose, and hemoglobin was between 6 to 9. Again, it was a prospective RCT between 13 to 14 among 60 women, and the secondary outcomes were also the percentage achieving hemoglobin of more than 12. So it was seen that the hemoglobin rise was higher at 6 weeks with FCM, which was comparable hemoglobin at 12 weeks. So essentially both will work, but it has been consistently seen that the rise is a little faster with FCM, and target hemoglobin of 12 was achieved in 75% of FCM versus 65%. And number of doses required was lesser. So I think these were some of the things which became important to understand, like in the previous, that there is a rapid and sustained rise with FCM when it was compared to iron sucrose. So higher serum ferritin in FCM. So if we look at this chart here, at 6 weeks, so serum ferritin when FCM was higher at 6 weeks, and again comparable at 12 weeks. So if we go through these studies, it's a consistent thing that it. So if we look at the final observations here, so mean rise of hemoglobin was around 5 gram with FCM and around 4 gram with iron sucrose. If we talk about a 2 gram rise, about 82% had a 2 gram rise with FCM. Why the absolute rise is important is that she may not move out of the anemia range, but she will have an improvement. And a 3 gram rise was seen in 53% versus 36% of iron sucrose. Now, this is the earlier study which started, where after which iron sucrose therapy was started in earnest in AIMS. And in this, again, we took pregnant women between 5 to 9 gram per deciliter with iron deficiency anemia. The intervention was iron sucrose. The outcome was rise in hemoglobin, serum ferritin from baseline to 4 weeks and 8 weeks. So it was a prospective study. It was not an RCT. It was a prospective study between 2009 and 10, and 100 women were taken. And secondarily, improvement in serum iron also was observed. So the baseline was 7. The dose of iron which was required was around 1700. The mean duration to complete therapy was 4.5 weeks. And I think this is one thing which would be different if we start using FCM, that it will be like 1 week we complete the dose. 32% had mild anemia and 68% had moderate anemia. So if we look data, then we found that the 67% achieved a hemoglobin of more than 11 gram %, and the mean weight of delivery, newborn, and adverse events were not noted. So, and consistently we have been adding 1000 milligram for iron stores. So I think that is one another area of controversy, because if you look at the original Ganzani's formula, it also gives 500. So, but in practice, we have been giving 1000 milligram for stores. So that is another thing. Now, this last one is about the systematic review. This was published in 2019. In this, which actually looked at treatment of iron deficiency with parenteral versus oral. So this was essentially FCM, not iron sucrose, not FCM, but this was iron sucrose. So this was 11 studies. It had both antenatal and postnatal component. So in the antenatal component, there were 11 studies with 1,633 women. Baseline was similar in both IV sucrose and oral group. So there was no significant difference at the baseline. Now, why I have made this table is that this is very interesting to see that at 1 week, overall mean difference was not significantly different. So whether you give oral or IV iron, hemoglobin improvement was not started to be noticed at 1 week. We all know about it, but it was also very evident. Now, at 2 weeks, the difference started coming on. So 7 out of 9 studies showed the difference. At 4 weeks, all 8 studies showed a significant difference in IVIs, with the overall mean difference persisted. So starting from 2 weeks onward, there is actually a gradual difference which is maintained between the IV iron and iron sucrose. So if you look about the cumulative analysis, even within a week. So this is a rapid replenishment of stores. So even though the data comes later, we can be sure that, okay, we are giving iron, it is going to go somewhere. If there is iron deficiency, it's going to get treated. So I think this was an important finding. Later on, of course, it persisted at 2 weeks, 4 weeks, 6 weeks, and the overall mean difference was persistently higher for the iron sucrose groups as compared to the oral group. So improvement starts within 1 week of IV sucrose, and there was a difference in the estimated mean ferritin level up to 3 times, 2 to 3 times as compared to both. So percentage improvement from baseline to post-evaluation was 500% in IVIS and 157% in the oral iron group. So I think this is like a straight thing that this will improve the iron stores. In the postnatal group, there were 8 studies consisting of 713 women. Baseline, both the groups were similar. And again, in terms of improvement in hemoglobin, within 1 week, there was no difference. It was increased in 39% of IVIS and 20% of 28% of 311% improvement with IVIS. So there's a larger positive impact. Higher mean rise of hemoglobin and ferritin is higher and faster in FCM. Improvement in fatigue score was better with FCM. Larger dose administration per sitting, hence lesser number of hospital visits are required with FCM. FCM was cost effective as compared to iron sucrose. If you see the number of doses that we are giving, number of times the patient has to come, the number of days lost of work. And no serious adverse effects were reported in either of these, any of these cases over a period of time. Now, just to, in the last 1 year, what have we been doing? I mean, just to look at our experience and the how much. So this was our median prevalence of anemia, which the data is just corrected under the Lakshya register. It's around 36. FCM is being routinely used in the Department of Obs-Gynae. Pregnant and postpartum are available in the hospital free of cost under JSSK. So if we want to give, we admit the patient and give it free of cost. So from March 2023 to March 2024, we just looked at our pregnant women who were at less than 37 weeks or postpartum women who delivered at AIMS with a hemoglobin between 6 to 10.9 gram %, and any other deficiencies were excluded. So the iron requirement is calculated by this Ganzani's formula, as we all know. Maximum sitting of FCM is 1000 milligram diluted, infusion over 15 minutes, and general condition is monitored. Fetal heart rate is monitored before and after the infusion. So this is a protocol that we are doing. The primary outcome was rise in hemoglobin from baseline at the follow-up visit. Secondary was any adverse perinatal outcome or any adverse events. So in the last 1 year, we've given FCM. This is a conservative estimate that, we have given a FCM to 153 participants, out of which antenatal is 135 and postpartum is 18. So the gestational age, mean gestational age, which infusion was done was 33 weeks. And in the postpartum women, it was the 6th day, between 4 to 9. Median dose is single dose. Usually we have given single dose. However, in 2 participants received 2 more doses. So if we look at the baseline hemoglobin, the range is around 8.2 and duration of pregnancy is 32 to 36. Out of our anemias, moderate anemia is in the women who have received is definitely because of moderate anemia. So 80% had moderate anemia, 16% had mild, 4% had this thing. Mean serum ferritin was 11. And I think this is an interesting finding. Now, I think one of our colleagues was asking if we do ferritin for all. Being at AIMS, we can do. So we're not suggesting it. So that's a discussion for later. But we do have data that we have done serum ferritin. And 80% are less than 15. So I think this is a huge amount of evidence to say that, there is iron deficiency to that extent that it is less than 15 and we can give a single shot of IV iron even without doing ferritin. So I think that is something that is a point to be discussed. Less than 30 was 18% and only 2 patients had more than 30 and they turned out to be thalassemia. So if we also look at this very interesting slide, see, initially, the mild anemia was 26%, less than 28 weeks, and the moderate was 74%. There was no severe anemia. But as the gestation advanced, the mild decreased and the moderate increased and the severe came into being. So essentially, there is one condition where we say that pregnant women are coming to us with anemia. That's a baseline condition. But if with advancing gestation, the moderate anemia is increasing, that shows non-compliance to oral iron. And I think that is something that needs to be taken into account. And that is the need also to say that there is a need probably to give IV iron a little earlier. So I think this is something that also, so initially we wanted to do a analysis from 28 to 34, but we have the numbers, we can do it later. But I think this is one important point, that as the gestation advances, the moderate anemia and moving to severe anemia is increasing, and there is a need to non-compliance of oral iron. So the hemoglobin increase was around 2.1 to 2.5, whether it was PNC less than 28 or more than 28 weeks. Another interesting thing that we have also mentioned again is to a mild anemia area. So she will not be without anemia. So it's important that we keep her on follow-up so that she does not relapse and she does not go. So these are some of the interesting or important findings that we wanted to put across, that within 2 weeks, there is a rise, but it comes to 9 or it comes to 10. But after 4 weeks, it's coming. So there is a gradual rise of hemoglobin. But if suppose she's 36 weeks already, you don't have that time of 36 for 4 weeks for the hemoglobin rise. So I think that is something that needs to be kept in mind, that it takes time to improve. So what are we going to do that? So if also looked at the rise by 2 grams, the average duration was 5.2 weeks. To rise above 11 grams, 37% by 6 weeks, and another 17% by 12 weeks. So if you actually want women to be getting out of anemia, so it doesn't go. So essentially, if you look at the other aspect of it, mild anemias also need to be given importance. It is both ways. So I think that is something that also is important. Again, severe anemia, we gave FCM and we saw the improvement, and then we followed her up. So we do give, if the severe anemia is early on in pregnancy or even less than 32 weeks, we can give IV iron. So no major adverse events were noted, and the newborn outcome, the perinatal outcome was also okay and nothing related. There was one patient with preterm labor after FCM. However, it was after 8 weeks. So there are multiple factors for preterm labor. Can't really say that it was because of that. So just to conclude, anemia is one of the most important underlying cause for poor maternal and fetal health. Parental iron is important for anemia control, for moderate to severe anemia, pregnancy, postpartum, reproductive age group, and intolerance and non-compliance. FCM is safe and effective in pregnancy. For us, we have moved completely to FCM. We are not giving IV sucrose anymore. Healthcare system strengthening regarding correct administration and maternal fetal monitoring for adverse event. I think that is one of the most programmatic challenges which are going to come if we want to escalate it to a very high level. There's just one thing that I would like to, 2 points that I would like to put forward going forward, is that mild anemia should be treated with much concern, because it will only progress to moderate and severe anemia. We cannot sit that, okay, this is mild anemia and nothing will happen, because within 2 months, she's going to progress to moderate anemia. And secondly, we must think of B12 deficiency. So I think that is something that I would leave everybody with, that food for thought, that anemia is this, but in lot of women that we always also get a peripheral smear done, and being here, we are privileged to also get the B12 levels done. So we are finding a huge amount, and there is adequate evidence. So I think that is also something that should be taken in together with IVR. Thank you very much.
Thank you very much, Dr. for giving us an extensive overview of management of anemia in pregnant women using parenteral iron in a premier tertiary care institution. And it has given us important information. We all know that FCM requires less number of doses, and it's can correct anemia over a shorter period of time. If Dr. Ravneet or you're okay, sorry. Yeah.
Since we're a little short of time, I'll keep my presentation very brief, and I'll briefly discuss on the experience and the work that the Department of Center for Community Medicine as well as NCEAR-A has done in the field of IV iron in the last couple of years. Next slide, please. You're changing? Sorry. So this will be the primary outline of my study. Uh, Multiple studies have been done on IV iron, some of which on intravenous iron sucrose and some on FCM. Most of the study population mostly included pregnant women or postpartum women with moderate and severe anemia. As per the current guidelines for severe anemia, the modality discussed now. So in the first study that I'll be discussing, it included pregnant women with moderate as well as severe anemia, that's from hemoglobin between 5 to 9.9 grams per deciliter in 4 days. In this, an overall mean hemoglobin change at 4 weeks was noted to be 1.76 grams per deciliter. And this rise in hemoglobin was much higher in patients with severe anemia as compared to that in moderate anemia. In the second study that we'll be discussing, it was again an observational study in which moderately anemic pregnant women were provided intravenous iron sucrose that was calculated as per the Genzoni's formula. And a mean change was noted in hemoglobin, serum ferritin levels, as well as 3 oxidative markers. Hemoglobin improvement was found to be 2.5 grams per deciliter over a 4 weeks period. And even serum ferritin levels had shown significant improvement. As for the oxidative markers, 2 of the oxidative markers that were done, that is the malonyl dialdehyde and ferric reducing ability of plasma, did not show significant change over the 4 weeks period. Whereas for superoxide dismutase, it showed a significant decline over the 4 weeks after IV iron infusion. The next study was done among, again, moderate and severely anemic pregnant women, in which a calculated dose of iron, as per the Genzoni's formula, were given with 300 milligram of IV iron per dose, and a mean change in hemoglobin was observed over the 4 weeks interval. The findings are similar to the first study that I had discussed, with similar findings in terms of higher change in hemoglobin, or the higher rise in hemoglobin in women with severe anemia as compared to that in moderate anemia. We also had a case study in which a pregnant woman with severe anemia had presented at 31 plus 5, increased by 4.2 per deciliter, and there was no major adverse events noted in this patient. So from this, we kind of drew that it might be beneficial. Intravenous iron, especially iron sucrose in this case, might be beneficial for the treatment of even severe anemia in cases where blood transfusion may not be feasible or refused by the patient. The next few studies will be discussing the use of ferric carboxy maltose, again in pregnancy and postpartum. The first study will discuss the effect of ferric carboxy maltose administered to postpartum women with moderate and severe anemia. Again, it was provided as per the Genzoni's formula. And after a 6 weeks interval, we noted a significant rise in hemoglobin of 4.2 grams per deciliter, as well as ferritin of 137.3 nanograms per ml. We also noted that the change in mean hemoglobin was higher in patients with a lower baseline hemoglobin category. That is, pregnant women with severe anemia was found to have a higher rise in hemoglobin 6 weeks after IV iron administration. In the next 1.9 grams per deciliter over a 2 weeks period, and at the time of delivery, the rise was up to 2.9 grams per deciliter. At delivery, we noted that more than 50% of the pregnant women had a normal hemoglobin status. Also, we noted a rise in the medium serum ferritin levels at both the time periods, though at 2 weeks, the rise was much higher as compared to that at delivery. The next study was all the studies that we have conducted, and other evidences were summarized, in which we have noted that there is significant improvement in hemoglobin levels, a faster improvement levels with IV iron supplementation as compared to that with oral iron supplementation, both in in pregnant women. And we also had tried to analyze the IV FCM versus iron sucrose, and we have noted that with FCM, the rise was much faster, higher, and it also aided a total dose administration most of the time with a single dose. From the side of NCEAR-A, NCEAR-A, I think, as most of you all here will be knowing, it's a technical support unit in matters related to anemia to the Ministry of Health and Family Welfare, Government of India. We have published 3 policy briefs related to IV iron use in pregnancy and postpartum. The first one was regarding the use of FCM in pregnancy, and another about FCM in postpartum women. And the recently one that we had released today, that is the role of IV iron in the treatment of anemia in pregnancy. The aim of the work done by NCEAR-A is so that we can translate the knowledge from research as well as science into policy and guide programmatic implementation later on. So this is one of the study that we have been planning into 2 groups, one receiving IV iron and the other IV FCM. It is planned to be a multicentric randomized control trial with the primary objective of assessing the impact of FCM on fetal outcomes, hemoglobin and serum ferritin levels of the mother, oxidative stress biomarkers, as well as the feasibility and acceptability of the IV iron preparations among pregnant women in the community. So this will be my take-home message from this presentation. That is, in our field practice area of Center for Community Medicine, which is located at Ballabgarh, we have 2 primary healthcare facilities and a sub-district hospital. From evidences that were generated from these and the use of iron sucrose over years in these centers have noted that these are found to be very effective for the correction of anemia and iron deficiency among pregnant as well as lactating mothers, as the postpartum women. And also, as was discussed previously in the previous presentation, the use of FCM has been a regular practice at the AIIMS Institute along with iron sucrose, and they have found to be very beneficial in moderate anemia in pregnancy, especially in cases of non-tolerance or non-compliance to oral iron or moderate anemia detected late in pregnancy. A total dose infusion of parenteral iron may be a substitute for blood transfusion, as was noted from one of the case studies that we found, but we need more evidence on this matter. But we recommend that AMB can adopt these practices for implementation at the community setting as well, considering, as was discussed by the previous presenter, Dr. Aparna, that the ferritin deficiencies, the low ferritin levels and iron deficiencies are quite high in our population. So even without testing for serum ferritin, it might be beneficial.
The iron deficiency should be plugged closer to the delivery, keeping the mother's health in view, but also, as Aparna alluded to in her talk, the mid-pregnancy level where it will hugely benefit the fetus. That is one new emerging discussion which will come up in the near future. The second thing is, from the FIGO point of view, we are sensitizing all the OBGYNs just because we cannot do ferritin at the point of care. We do not recognize that there is iron deficiency, which is a fact because there is immense evidence even from our own data that if you do estimate ferritin, you will have it very, very low in a significant number of women. So iron deficiency is already brewing there and manifesting as a mild iron deficiency anemia as the next phase. So looking at mild deficiency also as, something that can pass by is not appropriate. So iron deficiency anemia, 2 different things, is what we are trying to sensitize the OBGYN so that we pay more attention to investing our innovations even in the point of care ferritin if it first. And Dr. Baswal and the health system vouching for the efficacy and safety. And despite somehow the costs seem to be not so overwhelming. And when the FCM actually was introduced, we said, this is good, but this looks way too costly. And the cost calculations in terms of the travel, the time, the number of visits was not really taken on board. And also there was a small issue that FCM studies was not done enough during pregnancy. So that also was a deterrent to get started with that. But now, over a period of time, I think as per focused discussion today, the FCM has occupied the center stage, having got again a major push in the state of Madhya Pradesh to prove a point that in the major public health systems it can. And I think the newer studies are going to bring in the new kids on the block like the maltoside, etc. So we'll see how it goes. So on behalf of Bharti and myself, not only that we thank the speakers, but we would be quite delighted to have some points raised from our esteemed colleagues here as well.
So, thank you very much. And I think this gives sufficient confidence and the robustness of evidences that IVFCM or IV iron is good. My one question to Aparna and the others is, after giving a IV dose, when do you suspect that there may be non-iron deficiency anemia and one has to investigate? Should it be at 6 weeks or 12 weeks? Or
It's
4 weeks?
generally should be at 4 weeks. So suppose there is no rise after 4 weeks, then we start investigating for other causes.
Because most of the studies, what it appears is, although the rise occurs, but sometimes the rise may be delayed.
Yes.
In a program setting or even in clinical setting, is it wise to have it at 4 weeks or a little later?
Yeah, exactly, sir. It was a discussion that was happening earlier also. But sir, we have to also keep in mind that pregnancy is a time sensitive area. And if it was like a non-pregnant woman, then of course we have seen. But if there is a change, all the studies have shown that at 4 weeks, there will be an improvement of 2 gram%, or at least 1 to 2 gram%. So I think if we are able to document that, and sir, in our clinical practice, if she's not responding in 4 weeks, we would do a testing. But yes, I think it's an important thing, but from the clinical side, I think all of us would agree at a 4 week, especially only for pregnancy. Because
What is the value of not only looking at hemoglobin, but ferritin also? If the ferritin shows a good rise,
Yes,
which you have
yes.
shown,
So
will that
we
be a
need to
better
have
marker
baseline
that,
ferritin.
okay, even if hemoglobin has not risen, but
Yes.
it will rise?
So there are other surrogate markers like the reticulocytosis count, that it markers to show an improvement in ferritin. Definitely, I think that is another marker where we can do. If she has not responded, our first response is to do ferritin. So at 4 weeks, we will anyways advise to do a ferritin along with a CBC, and you look at other causes of anemia. So I think for the point of view of pregnancy, Dr. Hema ma'am, what do you
Yeah,
think?
Dr. Arora, recently the Foxy had put in a group of hematologists across the OBGYNs to discuss how best this should be dealt with, because there was a very strong opinion, like as it happened today also, that CBC and peripheral smear should be a part of the standard of care, because that will, in a very, very simplistic way, almost, get you to the point whether if all the CBC parameters are low, then it's likely to be iron deficiency. And then you look at the reports within itself, you will be able to find out the other forms of anemia as well. This has not yet become the standard of care, because we are more thinking about the ferritin as the norm for testing. So we will have to look at these, because it is emerging now that we have a quick fix solution for iron deficiency, but there are many other types of anemia that need to be looked into as well. Yeah, Gupta sir and Bikash.
I just compliment for the extremely good work which you have done. Do you think that this time has come in your data-based evidence that iron sucrose should be considered as an obsolete as compared to FCM? Or there is any still remaining evidence to suggest that yes, in this situation, this is still good, or that these are the evidence still required till that time we have both the options should be available? I put iron sucrose off the shelf from tomorrow because you said this gives a better,
Yes.
this has a safety, and which I do not agree with you. You said that the health economics impact you have done. You have not done.
No, not. So I said
You
that
have
we
only
not
done the
cost.
costing.
Yes.
But you said that the twice bringing coming may have, but
May
that
have.
has not been done.
Absolutely.
So unless you do the health economics complete, till that time, keep that comment reserve that this will be the health economic impact. If that is also likely to be, then I would say there is no case of iron sucrose to continue. Am I
Sir, in-
just one point?
Yeah.
And the second point, which may be, in one of the slide you mentioned that the phosphatemia was transient, but you said that it took 12 weeks to come back to normal.
Yeah.
It was not perhaps come back to normal, but this was observation after 12 weeks when it was found to be normal.
Normal, yes.
So we do not have the idea at what time this phosphatemia returned back to normal. So,
Yes.
and then thirdly, would you recommend, as mentioned by Dr. Michael, that in some cases there should be phosphatemia or serum phosphate level should be assessed, or it is not required? Last comment, do you find any logistic issue by giving routine IV as compared to non-IV? Particularly when you are giving with Vallabhgarh or maybe in primary health care center, or that may be a non-issue. Over.
Right, sir. So I think for the first point, I would say that I don't think we've written off iron sucrose as yet. Like you said, there is still, for us, I mean, for one institution, I would say that we are primarily using FCM, but we know of facilities where iron sucrose is available. There's a lot of thing about availability, accessibility. So I think till that time that there is more availability, practical issues, I think there is much merit in giving iron sucrose.
If it is only the availability issue, then we can find.
Yes. No, sir, I get your point. And also that it has worked till now. There is no saying that it has not worked. IV sucrose works. So I completely agree with you that till we have a good, economical evaluation done, there may not be a great point. But I personally feel that for the patient coming, going, of course, economics makes sense. And I think we need to have a research on that. But as a clinician, practically speaking, I would prefer to give FCM if possible. So that is the number one point, sir. And economics, yes, that is something that we need to look at.
Can I make a quick point? It hasn't been done in pregnancy, but outside of pregnancy, the economics have been done. And there's a clear benefit for the single dose infusion products, be it FCM, iron isomaltoside multicide are the only ones that have been studied because of the economics involved in terms of profit. Low molecular weight iron dextran and ferumoxytol haven't been done, but I assure you they would have the identical results. So they have been done, just not in pregnancy. And it's inconceivable that if a single study was done with economics as an outcome, that FCM or iron isomaltoside wouldn't be superior.
Right, sir. Yes. I think that's something.
So I would like to inform that Department of Health Research has commissioned health technology assessment of FCM, and that work is near completion, and we will have those results soon, sir. Thank you.
One last question from Dr. Vikas.
What about phosphatemia? Will you recommend the
Sir, in
phosphate?
our experience, routinely we are not doing. And I think we discussed with the hematologist also, and it comes out that, it comes out like a fatigue. Like, so that's what sets in. And most of the time it is confused with the pregnancy symptoms. So because it is transient, because it's largely asymptomatic, so I don't think that currently we advise it. But I think that is my take on it. I think people can also comment, senior.
Vikas?
So most of this presentation, I congratulate you for gathering the evidence, and which is practically very important. But I have a question, like that when I look at different formulation, today you say sucrose or new formulation, tomorrow maybe two new formulation will come. So there you always look at that, how you compare with the ADR profile. There may not be any serious adverse event, but how many ADR, what are the most common, least common, or rare ADR? And then we think of that is it resolved automatically, or you make a causality whether it is related to a product or underlying some other comorbid condition. Then I'll also look at that when we give it in a periphery. So how about quality of life? Then we also think of that, can I think of that, what is the fetal outcome? So there are several questions you need to know. Obviously, cost factor is very important in context with India, that if you approve, if you recommend, how many of them will have, kind of a affordability. Then we have a pan-India data. Obviously, it will be less, maybe 1 or 2% who are anaphylactic or allergic reaction to the preparation. And these are the data need to be generated actually, a real profile. Even if you say the product is already approved and company is doing PMS studies, let's gather a PMS study so that you can have a compare. 4 formulation is there, which one is most tolerable in terms of Indian population, in terms of zonal also. We are not going, little genomic approach is not there, but you can say that you are South India, North India, a different region, you can say that how common the area is, so you can address the issue. Obviously, we talk about prophylactic, management. So there also the issue, should you go for a prophylactic management in order to prevent? And there could be serious also. So that way you can gather that information and you can say it can be implemented as per standard treatment guideline. Thank you.
So,
So, excellent presentations by, all the three. That how much is the, concern is about the oxidative stress which we have with the, if we treat more aggressively, for that.
The study that was conducted in our setup is a very small scale study in which we've assessed 3 oxidative markers. But I think in the coming presentations, you can see more of the global studies and other studies conducted in India on this topic about oxidative stress that we discussed further.
There is not much clinical significance. So I'm a faculty in clinical hematology here. And so I've been attending the presentations. And so what I can say is that much of the debate about oxidative stress is more or theoretical rather than of any clinical significance. Dr. Y.K. Gupta mentioned about writing of iron sucrose. So it is of less utility in clinical practice because it is unrealistic to expect a pregnant lady or any patient to return for 5 visits. Whereas ferric carboxymaltose can be given in a single sitting. So it is more convenient and more patient friendly. There is little doubt with regards to efficacy of one molecule vis-a-vis the other. It is only about the patient friendly in way of single dose, single sitting administration. That is all I would like to say.
Utility, it becomes obsolete and it will, yes,
Flow of what is going to happen.
Yeah. So very evidence based before you saying that this need to be deleted. Lastly, I just mention one thing about the oxidative stress. I think we should not brush out the oxidative stress because oxidative stress is certainly related to ox-free iron present in the body. The sudden load of iron increases oxidative stress more than the gradual iron increase. There has been theory that if the iron correction is faster, the immunity decreases and the infection rates are more. I'm not going to propagate that theory, but I think that can also be one of the evidence which you can look for maybe tomorrow, that is there any relationship with this. This was long back, which was very hotly debated.
no, sir.
Well,
Anemia of
yeah,
inflammation
let
is
me address-
anemia of inflammation is yes, it's
right.
it's equally strong.
Hima, let me just take that. The largest study ever done prospectively on intravenous iron, these were all patients with chronic kidney disease, and it really does address the oxidative stress issue. You had a group of people who were treated reactively with lower doses of iron when there was evidence of iron lack, or proactively with higher doses. And in the proactive group, across the board, fewer hospital admissions, lower mortality, better outcomes, better cardiovascular outcomes than in the reactive lower dose. I think that issue has been answered in hundreds of thousands of published patients so far. There isn't a molecule of evidence that there is any clinical significance to oxidative stress. And Dr. Gupta, I think there are enough studies right now and enough prospective comparisons between ferric carboxymaltose and iron sucrose, and ferromoxetol and iron sucrose, and iron isomaltoside and iron sucrose, that indeed the time has come to put iron sucrose to bed and leave it in dialysis and nowhere else.
So the patients are not even able to afford iron sucrose costing 200. So we cannot just
Correct.
say that.
But you have to
Now-
see, when you have to calculate the economics, 1 dose versus 6 doses versus the indirect cost. I think she has not calculated the indirect cost. If the indirect cost,
So the FCM is 10 times more costlier than iron sucrose.
And also you have to calculate the cost of not doing anything about the anemia, which is again, it will snowball into so many different complications. So I think that
Yeah.
is also to be
I
kept
think
in
the
mind.
health technology assessment will give us very important information.
ये एक बार जब
and,
नेशनल लिस्ट में आ जाती है ना, कॉस्ट अपने आप कम हो जाती है, फिर नॉट कॉस्ट, प्राइस कम हो जाती है. If there will be pressure group, it can be.
Yeah, I think now we have come to a close of a very, very interesting session. And all the three speakers from AIMS have given us a broad overview of using FCM and IV iron in a community setting as well as in the OBGYN department. And there are very important